we know in practice, newly diagnosed adenocarcinoma, perhaps that he or she has features that would suggest that the chance of an EGFR mutation is higher, or maybe some other driver. But when you see the patient on Monday, you get the PD-L1 back on Wednesday, and it's 70%. But you still don't have the testing results back. I want you to kind of tell us your opinion of that and just reinforce that, because I think it's such an incredible. I've seen a number of patients who have come in ready to start pembrolizumab, and then we find out that they have an exon 19.
Right, so I'm going to reinforce, I liked MJ's comment before about the emotional emergency, because that's really what it is. The patient now knows that they have a cancer, they've had it for a long time, but they didn't know about it. They want to start treatment yesterday. All their family wants them to have started treatment yesterday. And if it were me, of course, I'd want to start treatment yesterday. So I fully empathize with that. I get where that's coming from. But it's our job to make sure they understand rushing to treatment sometimes means going to the wrong treatment and can potentially be harmful, especially given the possibility of increasing the toxicity of TKIs if there's been immune therapy given first. And that's been seen in multiple studies now, and I just presented my case earlier. So with those patients, talk through, it's a long visit. We know this has information. This is the data why in this setting, if you do have one of these driver mutations, it could actually be harmful. Let's just wait, and then I see them at least once a week, if not twice a week, until we've gotten them on treatment. Exactly, it's helping them through that time, making sure we've got the backup plan ready to go in case it ends up being negative, have those approvals ready, but then be able to move quickly. And again, with my practice, over half my patients have driver mutations, so this is the norm as opposed to the exception. And people are usually okay with that, but it does involve lots of time, lots of discussion, and lots of visits until you have that information. Now, what we do to get the information faster, we're not waiting 3-4 weeks for full NGS. We're doing a PCR-based rapid EGFR test, as well as FISH for ALK and ROS. And I think IHC for ALK is also a reasonable option at many institutions. But we're trying to get the more common ones done fast, so we don't have people wait quite as long. But if they're symptomatic, physically symptomatic, then I don't have a problem starting them on chemo, potentially chemo plus immune therapy, because chemo alone isn't necessarily a wrong choice. It's not as good, but it's not wrong. And adding immune therapy to hedge bets can be done.
So the NCCN calls out EGFR, ALK, ROS1, and BRAF. We also know there are things like RET and MET alterations and these sorts of things. So I think we need to think beyond the NCCN4, because there are other things
Absolutely.
that are out there.
Right, and so we're doing the NGS, but I feel like if you've got a patient, asking them to wait those 4 weeks can be really rough. And if they're completely asymptomatic, then yes, I have cases like that. But when they are symptomatic, or they really seem like they're probably going to be EGFR, and we can often get a pretty good sense of that given our patient population. We'll just wait for that to come back.
I agree. It's all about managing that wait. So I keep them busy by ordering a lot of things for 4 weeks. Ranging from their scans that they need to our distress counselor's visit, dietitian's appointment, acupuncture, so on and so forth.
It's seeing them all the time. Just, it's that same idea. They just need to feel cared for and not being ignored while they're waiting.
Yeah. If I'll add, there's recent data from MD Anderson about exercise for patients getting chemotherapy. And one of the things we sometimes underestimate is sarcopenia. So patients have a lot of muscle loss during treatment, and sometimes just inactivity contributes to it. So I actually try to get everybody on an exercise regimen, like their training, especially for their girdle muscles, the things that get them out of the chair and up the stairs. So it's something else you can add on to your preparation.
No, we have an exercise physiologist too, so I get all those appointments fit in for 4 weeks, and they feel they're coming every other day, even if I'm not seeing them.